pathologies that are encountered in day-to-day practice and how to deal with them. You may use this course as a base on which you can build your MSK ultrasound knowledge. And for those who are already doing MSK ultrasound practice, I really hope that we can refresh and enhance your knowledge and give you an idea about the stuff that we do in our MSK ultrasound practice. If there are any questions or queries, please do not hesitate to communicate with us. In my current talk, I will be discussing the common applications of MSK ultrasound and general overview of the common pathologies. So we already have MRI. Why should we bother with ultrasound? All right, MRI is already a well-established imaging technique for evaluation of all musculoskeletal pathologies. So why ultrasound? So while MRI was introduced in the 1980s and which has really revolutionized the way we do musculoskeletal imaging, musculoskeletal ultrasound has remained below the radar. Uh, and while MRI has been in the limelight, MSK ultrasound has slowly but steadily been improving uh, in the way we do musculoskeletal ultrasound imaging, but it hasn't been that popular. The reason which has been most commonly cited for MSK ultrasound not being that popular is that it is an operator dependent imaging technique. Uh, Another reason is there's lack of training in musculoskeletal ultrasound. So right at the start, my job is to at least convince you as a radiologist or uh, uh, as a radiologist that how good ultrasound is when it is compared to MRI. All right. So this talk is intentionally one-sided. MRI is already well established and does not need uh, more advocates. Rather, my goal is to convince you that the patients deserve to be offered musculoskeletal sonography as an imaging option. So I'm going to give you top 10 reasons why musculoskeletal ultrasound is a good alternative to MRI, or at least be considered as an imaging option. So let's start with reason one. So every patient can undergo ultrasound, all right? Uh, Patients with pacemakers, metallic implants, claustrophobia. So although some of these are now relative contraindications, claustrophobia is still one of the most common reasons why a patient cannot undergo MRI, all right? So if you look at literature, it's almost as high as 8.3%. So over here, what you see is we see a patient with a pacemaker, patient with various metallic implants, external fixators, and of course, what I spoke about is claustrophobia. Okay, so all these patients, if they require any form of imaging, let's say for a ganglion of the wrist, you really don't need to put them in an MRI. All you got to do is use ultrasound, and it is a 2-second diagnosis. Reason number two, this is something which not too many people know as well, that sonography can resolve finer details than MRI. Okay, the resolution of a 10 megahertz probe is approximately 150 microns, whereas the current resolution of a 1.5 Tesla MR with a FOV of 12 by 6 centimeters can give you a resolution of about 469 by 469 microns. So if you see, the resolution of ultrasound is almost 3 times as that of uh, MR. And with the current 18 and 20 megahertz probes, we are pushing the resolution of ultrasound to as low as 50 microns. All right. So let me give you an example. What we see over here on the left side is a cross section of the median nerve, which is done with a standard 12 megahertz probe. Over here, what you see is these hypoechoic fascicles over here, and in between the echogenic uh, perineurium of the median nerve. So, comparing with that, on the right side, what I've shown you is these are MR images of a patient with a normal median nerve. So, the image on top is with a 1.5 Tesla MR, where the image on at the bottom is of a patient which has been done on a 3 Tesla MR. What we see is, look at how well you can see the median nerve over here compared to the image of the median nerve on the left side. So ultrasound definitely gives you much higher resolution over here. Ultrasound allows real-time and dynamic examination of a patient. Now, dynamic imaging is the USP of ultrasound imaging. Okay, so ultrasound allows us to see the tendons, the pathologies in motion. So there will be certain pathologies which will not be well visualized on static images. That's where ultrasound is really, really helpful. So what we see is over here on the left, this is patient with a typical trigger finger. This is the A1 poly, and when the patient is trying to extend, you see that sudden gliding of the tendons. Whereas on the right side, you see that this is a patient with a full thickness tear of the Achilles tendon. You see a defect between the tendon over here, and when you do a forced plantar flexion, you see that the edges of the tendon, they approximate with each other. So this is critical information that the orthopedic surgeon wants to know. So this is going to significantly affect the patient management. Reason number four is the ultrasound probe can be placed exactly where it hurts. So in musculoskeletal ultrasound, there aren't too many surprises. All right. So most of the time, uh, the patient, uh, if you place a probe where there's maximum tenderness, that's where you will be able to find the pathology. Okay. So let's see, this patient had acute pain along the ulnar aspect of the wrist, and what we see over here is there is erythema over here, there was tenderness, and what we see over here is that there is uh, uh, some calcification adjacent to the pisiform bone. You see increased vascularity on power Doppler images, and when you uh, correlate this with a radiograph, you see an additional calcification that we see over here. So this is what ultrasound can really help you with. It's a focused imaging tool, and it can give you answers really quick, and life becomes much more easier. Reason number five, ultrasound can effectively image patients with surgical hardware. All right. Um, so I know on MR we already are doing great work with Mars, that is metal artifact reduction softwares, but then we're still reaching there. Whereas with ultrasound, we're already there. Okay, so this is a patient with a knee arthroplasty done, and all that the orthopedic surgeon wanted to know, that is there any effusion or synovial hypertrophy. All that we see over here, we just put the probe and we see that there's anechoic effusion that we see over here, and no synovial hypertrophy. We don't need to give any other contrast nor sedation, nothing, and we have an answer in 2 seconds. Similarly, this was a patient who had undergone a volar plate repair, uh, 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 who had undergone volar plating for a fracture of the lower end of radius. What we see over here is that there's a screw projecting along the dorsum of the wrist, and this has resulted in an attritional tear of the extensor tendon, resulting in a finger drop. So, once again, ultrasound is quite remarkable in presence